me. And if all of you can hear me clearly, please write it on the chat that you can hear me clearly. Sometimes at the end of the lecture, some say that the sound was not clear or anything else. That is why I kept the chat box open so that I may know that you can hear me. So, can anybody write it down whether you can hear me or not? Hello? Okay. So, you can hear me? Everybody can hear me? That's great. So, this is, as you know, this is a clinical session, and it's very difficult to continue with the clinical session when we cannot see the students, when we don't have appropriate interaction. So I've made this session very much practical so that you may know that how to approach this topic from the single based question point of view and as well as from OSCE point of view. So the topic is carcinoma of the endometrium, and all other cancers has already been done by Professor Nusrat. So now you must be in the gear to understand the approach to the tumors. So if you have any questions even in between, you can continue with the chat, and I may answer it later or maybe simultaneously, because I want all of you to understand it and take home something which will help you out also in your clinical practice as well as in your exams. So uterine cancer refers to tumors that arise from the uterus. Corpus, that is the body of the uterus. And because cervix, we take it as a separate part, and that we are taking it separately. So uterine cancer, when only the corpus is involved, and it can be an endometrial tumor that is arising from the lining of the endometrium, which is very common, or it can be originating from myometrium, which is called as sarcomas. So very rare. So in your exam, what we expect you to know is the CA endometrium. Now it's important to know that how common it is. And for every person, for every woman, the lifetime risk is 1 in 46. And the mean age for diagnosis is 62 years. So everybody can hear me loud and clear. Please, somebody write it on the chat. Is there any issue with the sound? Please write it on the chat. If you can hear me properly, anybody, please write it down. Is the voice okay so far? Is the voice okay? Because in one of my lectures, there was a complaint. Okay, thank you, thank you. Okay, thank you. That is why I've kept the chat open. And if you have any problem, in understanding anything, write it down. I'll see, maybe I'll address it simultaneously. Okay. So it's very important to know that the endometrial cancers, they are classified. Is it a type 1 tumor or type 2 tumor? That is when the histopathology comes. You need to know type 1 and type 2. This is a favorite question of single breast, when endometrial type 1 and type 2 depends. I'll just tell you what is type 1 and what is type 2, and depending on the histological subtypes, and they're also grade. Then there is type, other thing is grade. Grade is high grade or low grade. If it's grade 3, that means it is the highest grade. So type 1 tumors are endometrioid adenocarcinomas that are estrogen dependent. very important. So in obese women, one will have estrogen driven ovarian, this endometrial cancer, and arise from the background of endometrial hyperplasia. Now, type 2 tumors are usually high grade tumors. This is a question of single breast. Type 2 tumors are high grade tumors. And whenever, these are the buzzwords, whenever you see that it's a serous or clear cell tumor, serous tumor or a clear cell tumor, that is a high grade tumor and usually arises from atrophic endometrium. So remember that type 1 endometrial cancers are arising when there is hyperplasia. Type 2 from atrophic endometrium. So this is how you can differentiate in the when a question is given in the single breast. Okay. Now the risk factor, most of the studies has been done on type 1 endometrial cancer because these are estrogen dependent. And what is the function of estrogen? It causes proliferation of the endometrium. And uh, another hormone, which is this is progesterone, checks it. So if estrogen is more and progesterone is less, so the proliferation will go unabated and it will lead to endometrial hyperplasia and then endometrial carcinoma. So if a patient is taking progestin containing hormone, progesterone, so this reduces the risk of endometrial cancer. So progestogen is a something which is preventive, reduces the risk. Now, obesity is a risk factor. Why obesity is a risk factor? Because they are more likely to have an ovulatory cycle. And what is the meaning of an ovulatory cycle? When ovulation is not occurring, that means there is no progesterone. And when there is no progesterone, that means that estrogens are unchecked, causing proliferation unchecked. Also, in obese women, there is aromatization of androgens to estrogens in the adipose tissue. So, there is conversion of androgens to estrogens in the fatty tissue, and this is also providing continuous supply of estrogen. Okay. Then, what are other risk factors? Insulin and insulin-like growth stimulating factors. That is why whenever we take the history, we take the history whether the woman is diabetic or not. So endometrial cancer is more common in diabetic women. Why? Because the insulin and insulin-like growth factors stimulate endometrial proliferation. Then another thing, there's a drug which is called as tamoxifen. It is given in cases of breast cancer after surgery. So tamoxifen, it is a selective estrogen receptor modulator. We call it as SERM. So why after surgery, most women who are estrogen receptor sensitive are given tamoxifen, and it prevents breast cancer, anti-estrogen on the breast, and but it is stimulatory. It's a counter effect, a absolutely different effect on the endometrium. That is, it causes proliferation of endometrium. Okay, so then, but not all SERMs. Some women of breast cancer are taking raloxifene. If they're taking raloxifene, then this is relatively safer and has a lesser effect on endometrium. Then there is hereditary predisposition. That is, it is associated with Lynch syndrome. Lynch syndrome, it is an autosomal dominant condition. Again, a question of single breast, autosomal dominant Lynch syndrome. It is a hereditary predisposition, and in Lynch syndrome, it's run in families where there could be endometrium, cancer of the endometrium, cancer of the breast, and the colon. So when we take the history, we'll ask all these about all these cancers. Now, the lifetime risk of endometrial cancer in women with Lynch syndrome is fairly high. It is 40 to 60%. So it is a hereditary cancer. Endometrial cancer, like ovarian cancer, is also a hereditary cancer. Now, other tumors associated like colorectal, ovarian, depending on the mutation responsible. So the risk factors for type 2 endometrial cancer, like I just told you, it is not well understood. So we, since most are dependent on the risk factors, we really don't know the risk factors associated with endometrial cancer type 2. And type 1, I just told you that the type 1 cancers are estrogen dependent cancers. Then, stop away. Okay, okay. Now, prevention. It's a very important how what is the preventive aspect of endometrial cancer. Hormonal contraceptives, an intrauterine device containing progesterone reduces the risk of endometrial cancer. Hormonal contraceptive, this oral, intramuscular, or intrauterine devices containing mostly progesterone or combined even, reduces the risk of endometrial cancer. And other aspect of prophylaxis is that women with Lynch syndrome, they are offered prophylactic hysterectomy, and this is again protective following completion of the childbearing. So whenever we talk about the staging, we don't expect you to know the staging, but you should know only that stage 1, confined to the uterus, stage 2, cervix, stage 3, regional spread, and stage 4 is distant spread. So this much, I mean, just the broader outline, we expect you to know that tumor confined to the uterus, is it stage 1, 2, 3, or 4, and not the subclassification. Okay, so in your OSCE station, we can ask you that a woman is presented, she's 62 years old. So let's take this scenario that she's 62 years old and she has postmenopausal bleeding and now take focused history. So, such an station, what does it mean? Focused history means a woman who is a postmenopausal. We will not be taking a detailed obstetric history and because postmenopausal bleeding, it is a buzzword, and we have either 5 or 7 minutes for the station. So you have to ask all relevant questions. Patient is coming to you with post-menopausal bleeding. This is an actual exam station. So I've made a key of it. That's first of all, you'll ask about the profile of the patient. Okay. So how will you approach? You will approach start history taking by the personal profile. Age is important. Menopausal, greater the age, its peak age is around 60, 62, and if what's the age, what is the BMI? I just told you that obesity is a risk factor. So we need to find out the height and weight ratio as well. Then we will go to the presenting complaints. Naturally, now the patient has presented to you with if she's postmenopausal, then she will present to you with postmenopausal bleeding. If she can present with the foul smelling vaginal discharge. But if she is a premenopausal woman, she's still menstruating, then she will present to you with uh, this heavy, any kind of menstrual bleeding. It could be cyclical heavy bleeding, it could be intermenstrual bleeding, it could be postcoital bleeding. So Whenever there's irregular bleeding, any kind of menstrual irregularity or heavy menstrual bleeding, so this is a risk factor, or this is how it is going to present. Then in the history, remember that when we say take gynecological history, it includes menstrual history, it includes history of smear, includes contraception history, it includes fertility history, as well as any STI and any this surgery, gynecological surgery. So menstrual we are done. So we need to ask her whether she's up to date with her smear. Has her smear ever taken? Is she up to date with her smear? Because we don't know. It may be an extension of the cervical cancer into the uterus, which is presented as a postmenopausal bleeding. So smear history is important. Then contraception history or HRT history, like I just told you that if she's taking, if she has this a device inserted, intrauterine contraceptive device with the progesterone, which we call as Mirena. This is protective. If she's taking combined HRT, this is again protective. And then we need to ask about her fertility. And nulliparity is a risk factor. Nulliparity is a risk factor. So, and PCO, polycystic ovarian syndrome, is a risk factor because it is an anovulatory case. Then we need to ask her. Now, this is a station we are discussing, a station saying postmenopausal bleeding or heavy menstrual bleeding, near menopause or after menopause. And this is how we are going to take the focus history. So, medical history, hypertension, diabetes, obesity, three risk factors. So this is, see, the focus history means we know that we are asking regarding the relevant questions. Now the family history important, endometrial, bowel, ovarian, and breast cancer, very important. Then social history. Why do we want to take social history? Do not forget, I always, if any person, if I'm the examiner, and if any candidate takes social history, I give her full marks. Irrelevant कि उसने how much he or she has done in the other part of the history. Why social history? Social history, if somebody is taking social history, that means now you are concerned with the patient as a whole. That is, you want to know what is her life pattern, whether she's depressed or she's anxious about her condition, what kind of support she has at home. Remember that the patient's attitude, especially malignancy, the attitude will keep her alive. Her approach to life will keep her motivated, will keep her alive, will keep her cope up with her condition. So we really need to ask what she's doing for a living. Why do we need to ask what she's doing for a living? Then how much her life is affected, whether we need to suggest her whether she can continue with her profession or not, depending on the stage of the cancer. Then whether she has any kind of depression, that she feels low, or her mood, or she's anxious, or maybe is there any depression episodes, very important. Then what kind of support she has at home, from the husband, from the in-laws, because we want to help her. If she hasn't got a support, maybe we can give her some social support as well. We can provide her some support. And in the social history, smoking and drugs, everything comes. So when you take social history and you take understand the patient's problems as a whole. Now, what is kind of history we have skipped here is the detail of every pregnancy. It's not required. She's a postmenopausal woman. You just need to ask how old is the last born, and what is her parity, because we just want to see the risk factors. All right. So since this is a clinical lecture, so let's have made it clinical. This is how we are going to. So this social history and this history, focus history, is it clear? Do you want to ask any question regarding, because in that limited time, this is how you can. So, and also very important that you introduce yourself. I'm repeatedly saying that chat is open. You can write your questions simultaneously so that I may know that if you are with me and if you are understanding. Okay, so introducing myself again, I'm Krishna Haq. I'm Associate Professor, Gynae Unit 3, and I'm taking lecture of Professor Nusrat Shah. She was supposed to take the lecture, but she's in some meeting. All right, then, so something good about endometrial cancer is, and what we can, this could be a counseling point as well, that it usually presents in early stage. Now, since we have already done cancer of this ovary, all other cancers, they usually present late in stage 3 and 4, and so it's very difficult. But spotting, menstruation, intermenstrual bleeding, heavy menstrual bleeding, these are the symptoms, and this occurs early. Usually, endometrial cancer presents in stage 1, and if a patient presents with postmenopausal bleeding, so this is a red flag symptom. What does red flag means? That it's a high alert symptom, and we need to exclude malignancy in such cases. Although there could be other causes as well, it could be vaginal atrophy, it could be vaginal infection, it could be anything else. But depend on the age, especially in postmenopausal bleeding, we need to exclude malignancy. So, like I said, that abnormal. So now we have taken the history. So I've told you this history, uh, protective factor. Yes. Okay. Okay. So abnormal bleeding is the most common presenting complaint in premenopausal who variously complain of either it's a heavy bleeding, or it's irregular bleeding, or it is intermenstrual bleeding. Okay. So women at more advanced stages of the disease. So it's simple. Now remember, if a woman has presented to you, it is a single best question that if a woman has presented to you with abnormal bleeding, and she is also presenting with urinary dysfunction, or maybe bowel disturbance, or maybe respiratory problems, that means that this stage has already gone advanced. It's very important. When you take the history, you ask if she's with intermenstrual, it's a premenopausal, perimenopausal woman, and women at advanced stage present with abdominal pain, urinary dysfunction. So that you need to ask, do you have any urinary problems? Do you have any bowel problems? So that you may know the how advanced it is. Now, sometimes it is asymptomatic. Now, this point is very important, that sometimes endometrial cancer is picked up incidentally. You're doing a cervical smear, and the report shows abnormal glandular cytology. And so, maybe this could be cervical cancer as well as the endometrial cancer. Then we do the examinations. So, what is important in general examinations? So, single important factor in general examination. Can anybody tell me? Single important thing which you will see in general examination regarding a suspected case of endometrial CF. Anybody? BMI. Okay. So the first thing in the general examination that you're going to see is the height-weight ratio. Okay. Now, after general examination, like as we do all routine general examination, so what is important is that you do the bimanual pelvic examination. And when you do a bimanual pelvic examination, then uterus, in a case of endometrial cancer, uterus is not much enlarged because it's just the endometrial cancer. And there's usually no masses palpable. So you will find either a normal sized uterus or a bulky uterus, and even completely normal, because whatever is happening is happening inside the cavity, and it is not it is happening inside the cavity, and it is not outside, so that it will give a lump, or like in fibroids, which could be in the wall. So this is since endometrium, so it in may involve myometrium. When it involves the myometrium, the serosa, only then uterus enlarges. Otherwise, it may protrude into the cavity. So postmenopausal is a red flag symptom, and careful. So whenever you're doing the examination, it's important that you do be careful examination of the external genitalia. And then, why external genitalia? Because maybe the bleeding is coming from some kind of a local lesion. Maybe the genitalia is atrophic, and uh, we do speculum examination to see any lesion on the cervix, vulva, vagina. So it could be anything. Now, physical examination, like said, may be normal. Now, because we want to see the inside of the cavity, so we will do the first investigation is transvaginal ultrasound. In transvaginal ultrasound, what do we want to see? We want to see the thickness of the endometrium in a postmenopausal woman. And the cutoff criteria is 4 millimeter. If it is less than 4 millimeter, then we are not worried. It could be atrophy. We keep patient for follow. If it's more than 4 millimeter, we want to proceed and we want to see and we want to further evaluate by hysteroscopy and endometrial sampling or biopsy. Okay. So when if somebody is the question, sometimes one station is continued into the next. In one station, we keep the history of postmenopausal bleeding. In the next station, the examiner will ask you about the same case, the management plan, or the diagnosis and investigation, anything. So the mainstay for diagnosis is this is the sequence, okay? First transvaginal ultrasound, then hysteroscopy, and then through hysteroscopy we take endometrial sampling. Transvaginal ultrasound, it's a quick and accurate assessment of the thickness, and endometrium less than 4 millimeter, cancer unlikely. So we do not further evaluate unless there is recurrence of the symptoms. This is a buzzword. Don't say that we will not further investigate. We will further investigate if there is recurrence of the symptom. And any measurement greater than this, like you just said, so stereoscopy and biopsy. So this protocol should be on your tips. This protocol should be on your tips, that how to because postmenopausal bleeding, it is a very hot topic for the exam. So the postmenopausal bleeding. So let me do the recap again, or maybe we continue further and then I can do the recap, because this is can come in the exam as an off-key station. And I've given you a very simple protocol: what to ask in the history, what to look for in the examination, what baseline investigations, and this is the final year level, and we don't expect from you that you tell us more high-fi things. Now, hysteroscopy performed in an outpatient setting. Under local anesthesia, it is a flexible hysteroscope and it doesn't give pain. Only local anesthetic is required. Sometimes we give 2 tablets of paracetamol prior to introduction of the stereoscopy and the local anesthetic. General anesthetic is only required if there is cervical stenosis and if a patient is uncomfortable and cannot tolerate the pain, only then. So a thin camera, what will you tell the patient? That a thin camera is passed into the uterine cavity. So to allow visualization of the endometrium, and then directed biopsy. Or directed biopsy means that we are actually visualize where to take the biopsy. So very important, that's a directed biopsy. You've seen where the lesion is, and then you can take the directed biopsy. Then you wait for the histopathology report. So the histopathology report will describe you. Is it an endometrioid tumor? It's a serious tumor. It's a high-grade tumor. What kind of? Sometimes, along with the tumor, there could be complex hyperplasia with atypia, and this may also progress to endometrial cancer. So now the management. Management is surgery is the mainstay of treatment. Surgery, surgery, surgery. Okay? Surgery is the mainstay of treatment. And how much surgery? The extent of surgery will depend on the grade and stage of the disease and patient's comorbidities. What comorbids? She may be hypertensive, she may be severe, morbidly obese, she may be diabetic, she may be, or other unrelated like heart disease and all. So the standard surgery is total hysterectomy, removal of fallopian tubes and ovaries, bilateral salpingo-oophorectomy. So the standard surgery, so what is the standard surgery? Is total hysterectomy and removal of both fallopian tubes and ovaries. So TH, BSO in abbreviation. So this can be performed abdominally, that is, you give open surgery, or laparoscopically. And in the investigations, if they ask you besides routine, like besides ultrasound, besides hysteroscopy and biopsy, what other investigation? The other investigation, specific investigation will be MRI. So MRI, what is the function of MRI? Why do we do MRI? MRI helps in local this local extension of the disease. So if MRI suggests cervical involvement, this is a single best question. If MRI suggests cervical involvement, a modified radical hysterectomy is performed. What is important from your point of view that in this cuff of vagina, paracervical and parametrial tissue is involved to ensure adequate excision of the margin. Okay. Now, important, sometimes we need to give adjuvant treatment. So what is adjuvant treatment? Means along with the standard treatment, you are also giving some added treatment. So it could be post-operative radiotherapy. So post-operative radiotherapy to prevent recurrence. We don't expect you to know the details of radiotherapy. Sometimes hormonal treatment, intrauterine progestins, but this does not, but so it has a very high recurrence rate, so it's not recommended. Now, prognosis. Why do we want to know the prognosis? Because any patient who has this thing would be very much anxious and would like to know the overall how much survival is going to be there. The overall 5-year survival rate for endometrial cancer is 80% for all stages, although for stage 1 it is more than 90%. But there are certain adverse prognostic factors. So adverse prognostic factors, this is a single best question. Adverse prognostic factors include advanced age, grade 3 tumors, that is increasing grade of the tumor, type 2 histology, that is serous or this type 2 endometrial tumors, deep marmetrial invasion, lymphovascular space invasion, nodal involvement, and distant blood. That means the advanced age and how much it is spread will determine the prognosis. Okay, so now I will show you a number of videos so that you understand how to approach the patient. So I'll just ask them to load the video. Just hold on, please. Video. नीचे वीडियो भी है आप ये पार्ट में बंद कर दो जी
Did you know video series from the National Cancer Institute? Endometrial cancer. Know that endometrial cancer is the most common cancer of the female reproductive system? The endometrium is the inner layer or lining of the uterus, which is located in a woman's pelvis and is where a fetus grows during pregnancy. The 5-year relative survival rate for endometrial cancer is 82%. This means that out of every 100 women diagnosed with endometrial cancer, about 82 will still be alive 5 years after being diagnosed. Because survival statistics are based on large groups of people, they cannot be used to predict exactly what will happen to an individual patient. Endometrial cancer is most commonly diagnosed in women ages 55 to 64. White women have the highest incidence rate of this cancer. However, the death rate for Black women is much higher than that for women of other racial and ethnic groups. Research is being done to understand the biological differences of cancer among different racial and ethnic groups. Lack of medical coverage and unequal access to improvements in cancer treatment may contribute to these observed differences. Symptoms of endometrial cancer include pelvic pain and unusual vaginal discharge, including bleeding. Anything that increases your chance of developing the disease is called a risk factor. Obesity, high blood pressure, and diabetes are factors that increase the chance of endometrial cancer. Women taking estrogen without progesterone for menopausal hormone therapy have a higher likelihood of developing this cancer. Talk with your doctor about your risk factors. Anything that decreases your chances of developing the disease is called a protective factor. Endometrial cancer protective factors include taking oral contraceptives, pregnancy and breastfeeding, being physically active, and keeping a balanced diet. Avoiding risk factors and increasing protective factors may lower your risk. For more information on endometrial cancer, go
Okay, now I'll share with you how you are going to take the pipal biopsy. This can come as an auscultation.
The endometrium is the inside lining of the uterus.
Can you see the screen?
Is the removal of a sample of tissue from the endometrium.
Can you see the screen, everybody?
A biopsy may be done to screen for
Okay,
cancer or precancerous cells. To determine the cause of irregular bleeding or to investigate fertility problems. This procedure can also check for infections and monitor the effectiveness of certain medications. An endometrial biopsy can be done in your doctor's office in 10 to 15 minutes without the use of a sedative. Your doctor will first do a medical exam to determine the position of your uterus and then place a speculum in your vagina to open it up and keep it open so the cervix is visible. Your doctor may use another instrument called a tenaculum to grasp the cervix and hold it steady during the procedure. Your doctor will then pass a long, thin, flexible tube called a pipelle through the vagina and cervix and into your uterus. The pipelle is equipped with a piston-like device that creates suction when pulled. Your doctor will spin the pipelle and move it up and down in the uterus while suctioning up an adequate sample of endometrial tissue. Then remove the pipette and place its contents in a container. Your doctor will complete the procedure by removing the tenaculum and speculum. After the biopsy, some patients are able to sit up immediately and feel minimal cramping. Others who may feel some dizziness will be asked to lie still for about 10 to 15 minutes before being released. An anti-inflammatory medication, such as ibuprofen or naproxen, is often prescribed to minimize any menstrual-like cramping or discomfort. Your doctor will send the sample to the
Yes,
lab for testing.
I'll start the
Results
video
may be
again.
given to you by telephone or during a follow-up appointment with your physician. The endometrium is the inside lining of the uterus. An endometrial biopsy is the removal of a sample of tissue from the endometrium for testing. A biopsy may be done to screen for cancer or precancerous cells, to determine the cause of irregular bleeding, or to investigate pudding, or to investigate fertility problems. This procedure can also check for infections and monitor the effectiveness of certain medications. An endometrial biopsy can be done in your doctor's office in 10 to 15 minutes without the use of a sedative. Your doctor will first do a manual exam to determine the position of the uterus, and then place a speculum in the vagina to open it up and keep it open so the cervix is visible. Your doctor may use another instrument called a tenaculum to grasp the cervix and hold it steady during the procedure. Your doctor will then pass a long, thin, flexible tube called a pipette through the vagina and cervix and into your uterus. The pipette is equipped with a piston-like device that creates suction when pulled. Your doctor will spin the pipette and move it up and down in the uterus while suctioning up an adequate sample of endometrial tissue. Then remove the pipette and place its contents in a container. Your doctor will complete the procedure by removing the tenaculum and speculum. After the biopsy, some patients are able to sit up immediately and feel minimal cramping. Others who may feel some dizziness will be asked to lie still for about 10 to 15 minutes before being released. An anti-inflammatory medication, such as ibuprofen or naproxen, is often prescribed to minimize any menstrual-like cramping or discomfort. Your doctor will send the sample to the lab for testing. Results may be given to you by telephone or during a follow-up appointment with your physician.
Okay, so the first video was regarding the recap, what we did, the risk factors, and all. And the second video is about this pipette. And this is in this, we have been taught about this, we have showed you this, and in this regular sessions when you are coming to the walls, and this can also come in the exam if there is like face-to-face exam, that we can keep it as a station, and a small uterus can be placed, and we can ask you how to do a papel biopsy, or at least identify, or at least tell us the principles. So all these videos are since we cannot show you right now practically, so, Sarah, Mispa, you said that to replay the video. I hope were you all able to see the video? Were you able to see the video through screen sharing? Yes? Okay, thank you. Now, another station. So, I've made videos of the stations only, and could be that the patient has ultrasound has been done. Scenario is this could come in your exam, that a patient's ultrasound, a postmenopausal bleeding, patient's ultrasound has been done, and this endometrial thickness is say 5 or 6 centimeters, which is more than the threshold level. Threshold is 4 millimeter. Now it's more than the threshold level. And now when you were taking the pipal sample, it could not be taken because of pain. Now you have to do it in stereoscopy. So, what will you tell the patient? How will you tell the patient? What will you tell the patient? So, the first thing, what is the first rule is introduction. So, how will you introduce yourself? Anybody? How will you introduce yourself? How will you introduce yourself? That who are you? How will you introduce? Because last exam, nobody was able to introduce themselves. How do you introduce? What do you say? Anybody? Write it down on the chat. How do you introduce yourself? Misbah, Alize, anybody? How do you introduce yourself? Because like in previous exam, I don't know who taught you this. Everybody was saying, मैं उस टीम का हिस्सा हूँ जो आपको देख रही है. This is not the way to introduce yourself. Is you will tell your name to the patient and you'll first confirm the name. Yes. Or you can say that I'm a final year medical student and I'm there to help you and my name is this. What's the harm in telling your name? When you want to know the patient's name, then there is no harm in telling your name as well. That because it's always good to identify the patient by name and to tell your name that, okay, you can say that I'm XYZ, I'm a final year student and I'm there to help you. I've read your case. They don't know how to start the counseling. Say that I've read your case. And second point is that you have to confirm the name of the patient always. We have marks for this as well. So when you are introducing, you say, like if I introduce myself, I'll say that I'm Dr. Haq and I'm one of the doctors in the clinic today, and I have read your case, and it says that you are 30 years old, you're 62 years old, and that you had bleeding after your menses were over, and some biopsy was tried through the plastic cannula, but this has failed and this was very painful. I'm really sorry to know about that. It is painful. And now you're here to discuss further plan. So this is called as rep. Okay. So first is intro. So you have marks, intro 2 marks. So we are introducing yourself and when you are telling who you are and you're also telling who the patient, I want to know whether you are talking to the right patient, you have the right case or not. Always name, full name and age. Very important. Then number one is introduction. Number two is rapport. How will you build? How will you get her feel her comfortable? That is, you have to show some professionalism. Okay. So how will you show professionalism? That you have already gone. You do. Why have you come today? आप क्यों आई हैं बीबी? This is not the way to say it. Huh? We cut down. So what we do is that you tell the patient that I have read your case scenario, I've read your case, that you are here for this, and I'm there to help you. Because we expect that from now onwards, this is a case which has been referred to you, and from then onwards, you are going to, because time is very short in OSCE and you have to rush. And at the same time, you have to be very, make the patient comfortable with you. So it's important. And then you will tell her that you your you have been previously evaluated. Now remember that the station is not history taking. Remember to read the task. What is the task? Task is that you have to explain that the bell has been painful. She's a case of postmenopausal bleeding. And now, further plan. You are just explaining her the plan. Don't take the history. You're not taking the history. So you can just ask her briefly, how are you doing? And I understand that you had a menopause 10 years back and now you've been bleeding and your debel has been attempted and very sorry that this has been very painful for you. And now we'll see that we'll take you to the theater and we'll put you to sleep so that it's not painful for you. And then we'll introduce a very flexible instrument inside the mouth of your womb so that we can and a camera is also attached to it so that we can visualize so that we can see what is if there is any lesion, any growth inside the cavity, and then we'll take a tissue from that and we'll send it for test to see or to exclude cancer. So, see, there is no medical jargon. It's very important that you know the lay person language as well. It's very important. We don't have to say that we'll take the biopsy, we'll do this. No, we'll introduce hysteroscopy. She doesn't know what is hysteroscopy is. So, you must use the layperson language to explain it to her. And so I have another video where consent has been taken because this is the case video I have, and look at the body language, look at of the patient, and as well as the body language of the this doctor. Need to see everything.
Scene 5. Consenting for procedure under general anaesthetic. This scene shows a doctor obtaining consent from a patient for a diagnostic hysteroscopy. She presented with bleeding after her menopause, and a transvaginal ultrasound scan demonstrates an irregular endometrial measuring 12 millimeters.
Everybody can hear
The
and see.
doctor was unable to obtain or propel. Hysteroscopy and endometrial sampling is indicated. Unfortunately, I was unable to sample the non-endometrial tissue, so to exclude abnormal cells which may be contaminated. I want to go into detail how much and we want to information line for the body. Don't have to reach an operation, but the risk of abnormal cells which are causing disease to the secure plastic posture. Worries about operation. I just don't like the thought of going to sleep. How long will I be asleep for? The operation lasts about 20 minutes, is that right? Well, that's amazing. I thought it would be much longer. The other alternative is that the safest system I found out last examination just to be comfortable. I didn't want to come like that. Now, I'd rather have the operation so I can get some analysis, and I'm not sure I can sleep. Well, that's not it's a really short one, examination. We'll process exactly the document so it's inside. There's no way it's not about feeling just like there are also risks to the operation as we discussed. Some common risks are infection, where the disease risks are damage to the business, damage to the such as the body. Now, if you thought that it's exactly what to do inside, larger parts of the time. It's all very rare, not much to see. It sounds very frightening. I thought you were just going to take it. That's about as a country, it's dynamic. Why second as long as the damage is rare, I think that's okay. No, I suppose not. I want to find out if anything else is going on, and this does seem to be the best part. Where should I sign? Right, so here's the consent form. This figure all of the risks to the operation along with these changes. The operation itself is called this is which is the camera. that endometrial wires are usually cytokine cells. Can you see that zinc inside the cell next to you? So can I just suggest that you take this home with you, along with the other information about preparation to get ready, give you some time to think about it and add it to your head if you have any questions. I know that there's a lot of information to take on all at once. Go home and ask any questions. It's actually encouraging to visit and information. I make myself listen to this with my chat. Do you have any questions? That's all fine. Yes.
You want to see this again, or are you able to hear this? This is the maximum volume. Yes. Excuse me, sorry. Chat box open with you.
madam.
The sound was lagging. Okay, but it's this the maximum sound. Okay, I'm very sorry. This was the maximum sound, and okay, let me show you another one. And like she was taking the consent, and the link to the video. Actually, I have this is the copyright. This is not available. I have paid for this video. This counseling video I have paid for this. Okay, so I've just shown you so that you understand. So this is not available in YouTube, or this is a paid video. So just wanted you to see how the body language is. And in continuation with this one, I'll show you another one. Now the biopsy report has come, and it shows it's an endometrial cancer. So how you're going to break the news? So how to get the thing started? What is the rule of breaking bad news? This can also come as an station. So how will you do? How will you do this? Breaking bad news. What is the first rule of breaking the bad news? Anybody? Because if you followed, even if you don't know, if you don't know ABC of C endometrium, and if you have followed the rule, you can still pass. So what is the first rule? Anybody? What is the first rule of breaking the bad news? Anybody? Can you all hear me? Yes? Are you all with me? Can you all hear me? So comfort the patient. Okay, yes, very good. Number one, the comfortable position of the patient. Number two, how will you make the environment suitable? Ramsha, how will you make the environment suitable? We'll ask, so they ask her, has anybody come with you? Do you want anybody, since we are going to talk about the report, do you want somebody with you? Okay, then